Welcome back to another episode of Medical Staff Spotlight. Today we'll be talking to Dr. Stephen Wagner, who's the Medical Director for the Interventional Radiology Program for Jefferson Health Northeast. Dr. Wagner, thank you again for talking with us today. Tell us a little bit about your background and how you got into interventional radiology.
My exposure to medicine actually came at a young age when I was 7 years old. I had actually suffered a cerebral aneurysm that had ruptured and bled and actually led to a stroke. I wound up spending 6 months down in St. Christopher's Hospital for Children, where I had an expert neurosurgical team repair the aneurysm and get me on the road to recovery. That type of experience, as you can imagine, could have one of two outcomes. Either the person undergoing it would never want to see a physician again, never set foot in a hospital, or like in my case, actually spurred my interest into medicine and technology and pushed me on to become a physician myself.
Give us a sense a little bit of some of the procedures that an interventional radiologist would do in a room like this.
Interventional radiology is an all-encompassing subspecialty. So we're doing a variety of procedures that affect many different organ systems. The procedures are minimally invasive, meaning we're going through a small needle through a blood vessel, an artery, or a vein, or even a small nick in the skin where we're guiding a needle through the skin into an organ under imaging guidance. The treatments that we do often encompass a wide variety of different disease states, pathologies, and encompass us crossing paths with many other subspecialties in the medical field. One of those procedures that we do focuses upon oncology. In tumor ablation, we're using CT or ultrasound imaging to guide a needle through the skin into a tumor. This can be done in the liver, in the lung, in the kidney, in the adrenal gland, or even in the bone. In those cases, we're then applying energy, either heating or freezing, to kill those cancer cells locally. Another oncology treatment that we often perform is called Y90 treatment. This is a treatment where we can help patients who have either primary or metastatic liver cancer. In these cases, we're going through the arteries, through the femoral artery into the arteries in the liver, and injecting these small, literally microscopic beads that contain radiation, and depositing the radiation in targeted fashion into the tumors.
I've certainly in my career path seen you work with traumatologists for splenic injuries and for liver injuries and so forth. What other areas do you cross with routinely?
Often the intensivists and vascular medicine. One area that we commonly are called to help with are patients who have vascular diseases. So some of them are life-threatening, such as pulmonary embolus or deep vein thrombosis. We have techniques and equipment that allow us to either help dissolve those clots in the legs or in the lungs or other areas of the body through a catheter, or even newer technology where we actually have the ability to go in and extract those clots. In women's health, women are often suffering from uterine fibroids. In that case, they may have pelvic pain or bleeding. Uterine artery embolization is a procedure that we perform here where we can guide small catheters into the arteries of the uterus, inject particles, cut off the blood supply of the fibroids and allow them to shrink and help them manage their symptoms. We also assist in men's health. A new treatment that we're offering here is called prostate artery embolization. So in men who have BPH or enlarged prostates who may suffer from frequent urination, difficulty urinating, or even bleeding, we can go into the arteries of the prostate endovascularly, inject small particles to shrink the prostate and also alleviate symptoms.
Tell me a little bit about how the training for interventional radiology differs from general radiology.
Medical students now apply directly to an interventional radiology residency in which they complete 6 years, 2 years of surgery, 2 years of radiology, and 2 years of interventional techniques. In the past, interventionalists were simply proceduralists performing high-end procedures. Currently, we're now a part of the patient's clinical care and continuum of care.
Can you tell me a little about some of the devices or catheters or even imaging modalities that you use regularly in providing interventional radiology care to your patients?
The devices that we use can include ablation technology. As I mentioned, guiding a needle into a tumor. We actually can use microwave, just like the microwave in your home, transmitted down an antenna into a tumor to treat that tumor. We discussed patients who present with massive pulmonary embolus, a life-threatening condition. There are new devices where we can go in and extract those clots from the lungs or from other areas. At Jefferson Northeast, we're actively developing a pulmonary embolus response team in which we'll have a multidisciplinary review of these cases with emergency medicine, intensive care medicine, and interventional radiology to determine what the best approaches are for that patient.
In imaging modalities, are you using ultrasound, CT scan, fluoroscopy regularly? Is there one modality used more than the other?
I would say all modalities are used equally, and nowadays we're often combining modalities. So we have techniques where you can use fluoroscopy and CAT scan at the same time, or fuse imaging together. The same with ultrasound. So as things evolve, so does our practice.
Obviously, there's a lot of moving parts with interventional radiology and a lot of different pieces of equipment. Tell us a little bit about the team that you work with to make that happen.
We've consists of several interventional radiologists, a few new staff members, Dr. Michael Fickus, Dr. Joseph Luca, and soon to be Dr. Sean Morato. We also have a high-level physician assistant, Erica Voorhees, who helps with not only the procedural aspect of the care, but also with communication and longitudinal follow-up of patients. Day to day, when I'm doing these procedures, in the room with me is one of our interventional nurses, critical care trained, who's watching the patient during sedation and monitoring them during the case to make sure they're safe and comfortable. I also work side by side with our interventional technologists who are trained in the imaging equipment and the devices, and they're physically assisting me with each of these cases, making sure I have the right devices at the right time and that we're getting the appropriate imaging.
As you're growing the program, does interventional radiology have the ability to grow at all three campuses? Like, do you see one area growing more than the other?
The enterprise and the Northeast administration extremely supportive at developing IR for our patients in the community. In fact, we're in the process of building an entirely new ground-up IR division at our Torresdale campus, which will include new angiography suites, outpatient areas, consult space, clinic space, and will make us a real one-stop shop for all interventional needs.
Dr. Wagner, thank you so much for taking time out of your busy schedule to be with us today.
Thanks so much for having me.
Thank you so much for joining us for this most recent episode of the Medical Staff Spotlight. Till next time, be safe.